And the webinar's live.
Thank you. Good afternoon, everybody, and welcome to the Cheshire Clinical Commissioning Group Primary Care Commissioning Committee. This is the meeting that's held in public, but it isn't a public meeting. And we're holding this meeting in two parts because the second part of the meeting will pertain to an application from Danebridge Surgery to close its branch at Sandy Way. And because of the technology involved, we're not able to have everybody in both meetings, so we've split it into two. And I just hope that everybody manages to join the second meeting as well through the webinar link rather than through MSTs next time. Okay, in terms of the meeting today, I would like it, please, if people could indicate in the chat box if they wish to speak. I'll try and keep an eye on people that are waving at me frantically if they can't. And I'm hoping that we'll finish probably a bit earlier, and maybe we might have to have a break in the middle to get a drink, because I know that people are working in an environment at the moment that's pretty hot. So we'll see, but we'll see how we go on. So in terms of absence, Emma, I know you can hear me, but we can't see you. Can you tell me who we've got apologies from, please?
Hello, yes, we have a few apologies. We have Dr. Paul Bowen, Dr. Sinead Clark, Tracy Cole, Suzanne Horrell, Dr. Andrew McAlevey, Denise Smith. We've also got apologies from Carla Sutton, although Sarah Smith, sorry, is attending on behalf of NHS England, and Will Greenwood, although Simon Powell is attending on behalf of the LMC. That's it.
Thank you very much. In terms of declarations of interest, I know there will be some this time with some of the agenda items. Has anybody got anything else to declare in terms of the agenda that's not already on the declarations of interest that we publish? No, I'll take that as a no. I'll cover declarations of interest each time that we actually Okay, so let's move on to the next item, which is questions from the public. I've had a question from Councillor Phil Herbert, who is the Councillor for Hertford and Greenbank Ward at Cheshire West and Chester Council. And his question is, owing to the difficulties in receiving primary care created by the construction of over 1,000 new homes, it would be a welcome reassurance to hear that the Section 106 monies from Redrow plc, which is £123,000 ring-fenced for the Clinical Commissioning Group, will be used to alleviate the situation directly within the catchment area that serves my ward, Hertford and Greenbank. James, I believe that you're going to give the committee a reply to that.
Yes, you want that reply now? Yeah.
Please.
Okay, so Section 106 is based around the Town and Planning Act of 1954, I think, and it's a section within there. It requires, when we get pre-applications, or we get a list of applications from, or registered applications from the local authority, we do an analysis of those. If there's going to be large developments or nursing homes, then we can put an objection to ask for Section 106 funding. That is, the amount of money that we request is based on a formula that we've been using for a number of years, that is to do with NHS indices and some data from property services. So that's how the calculation comes about. The application or our objections goes in and is considered by the developer, and they will either say, yes, we're happy with that, or no, we're not. If we are successful, we are able to draw down that money via the council at the various trigger points within the Section 106. So it tends to be, they're going to build 1,000 houses, and the trigger points will be 250, 500, 750 and 1,000, and there'll be a staged payment for that. This particular application is served by 7, the catchment area is covered by the 7 GP practices within Northwich, and the money would be potentially shared equally. It would have to be a PCN and a CCG decision on how that money would be spent, and we would have to provide evidence back to the council to draw down on that money. So it is a longish process. Some developments have a number of years, so you could have from the start of a development to the end, it could be 5 or 6 years before we actually get the full value of that money. The slight complication is the money is not able to be held by the CCG. It is deemed as capital, and therefore NHS England should technically receive that money. We are in negotiations with NHS England because I believe there is a disparity between some of the NHS England some of the CCGs in the south and some of the CCGs in the north, in that we can't access, some can access that money and use it directly, and some have to give it over to NHS England. So those are some of the technicalities and challenges we've got. Clearly, it's 123,000 potentially split between 7 practices. And it should only be spent on bricks and mortar. It can't be spent on anything that is considered revenue, sort of staffing costs, etc., etc. And we would need to engage with the local PCN as part of their estate strategy to understand how they want to spend that 123,000.
I assume that a written response will be sent to the elected member after the committee.
Yes, we will send a written response, yeah.
That's lovely. Okay, thank you for that, Jane. Let's move on now to the minutes of the Primary Care Commissioning Committee on the 22nd of April. Seems like an awful long time ago. I know these have been circulated to all members of the committee that were in attendance. Has anybody got anything that they've spotted, though, in the minutes at all that make it factually inaccurate? No, so everybody can agree those minutes? Yeah, thank you very much. So I'll move on then to the action tracker, and we've got 4 items, I think, on the action tracker that are still live. The first one was an update from Katie around waiting lists for childhood immunisations, and that's in the paper today. The second one was an update from Katie on Valparaiso Pregnancy Prevention Programme. That isn't Katie. I don't know if you want to say something about that. Would you want to bring that to another meeting?
I can bring an update to the next meeting if you like. There is ongoing work. NHS England has written to all practices regarding this, and we've got a team between meds management and quality to look at how else we can look at improving the completion of these annual reviews.
Okay, that's lovely. We'll put that on the tracker for next meeting. Thanks, Katie.
Okay.
The next one is, I have met with my colleagues in terms of the quality update, and we've reflected what we decided in the report that we get into the committee. And finally, James, was an item to include update on improvement grant monies in the next estate report. I note it's not in the report this time. Can that come to the next committee as well?
Absolutely, yes. We have taken it to the Estates Committee, but I've alluded to include it here, so I will bring it to the next meeting.
That's lovely, thank you very much. Is there anything else that I've missed on the tracker that either isn't in progress or needs to be closed? No? Okay, that's lovely. Right, we'll move on then to the substantive part of the meeting. The next action is about the Primary Care Committee Terms of Reference. We circulated this to members of the committee by email because of the timescales involved with getting this ratified. And the committee agreed that to the amended terms of reference. There were only slight amendments. And it actually went to the Clinical Commissioning Group's governing body last week and was accepted. But I brought it back here just so that we can formally put in the minutes that we have accepted it. So I'm assuming that as it's gone through the governing body, everybody is okay for me to put that in formally into the minutes for next time. So I'm going to move on to item 2.1, which is the risk register update. Chris, do you want to take us through that?
Yeah, I'll just make sure everybody can hear me. Good. Okay, so my name's Chris Lees. I'm the Associate Director of Primary Care for Cheshire CCG. This is an updated version of the risk register. As you'll be aware, committee members have asked that this came back. As we didn't meet during the COVID times, this takes into account some of the developments over that period. It is for approval and for noting. Just a couple of things that I'd like to add. First of all, you'll notice in the mitigation actions, they have all been pulled up into the top box because the bottom of the PDF document doesn't capture them all. So that's why it looks like it's sliced in half on the PDF, but actually all mitigation actions have been captured that we've put in so far. And I just wanted to make a note on the risk regarding primary care stability and resilience. I will be adding a section on Primary Care Support England, which I know a lot of practices have raised with us, and the LMC have also, just to put that down as an ongoing issue which is affecting and troubling practices at the moment. You'll also see in the paper that I've put who owns each risk and the governance process for that risk to be owned and managed, so it's a work in progress rather than just as it is. So if everybody's happy, that's basically it in a nutshell. It will come back to the committee at every meeting, every quarter.
Has anybody got any questions for Chris? No, I can't see anything in the chat box. So the committee asked to approve the first iteration of the revised risk register, noting that the management of risk and scoring of each will be reviewed and maintained outside of the committee with the structures that are outlined in the paper. So can we all agree that? Yes, some nodding heads, lovely, thank you very much. So let's now move on to 2.2, which is you again, Chris, I think. It's the Primary Care Contracting Commissioning update.
It's me again. So the paper is essentially in 3 parts. We'll do them all in sequence. The first part is mostly for noting. It's the usual general update on primary care commissioning and contracting issues, noting that Sandy Way branch surgery will be discussing in part 2. I just add at this point that this was written before the information regarding the COVID-3 phase 3 booster program came out. So that's why that's not mentioned. It wasn't deliberate. It was just that came out after we'd written the paper. So we do have to note that that has now come out rather than me referring to it in the paper as due any minute now. The second 2 sections are for approval. The first one refers to structured medication reviews, which is part of the primary care network directed enhanced service, and we need to sign off as a CCG our approach to that. This has been to the LMC, the local medical committee, and through stakeholders who have agreed this position, which the medicines optimization team have put in as that paragraph, noting that I'm not clinical, so the associate director of medicines optimization has written that, and she is a clinician. And the third bit is a request to ratify the approval of the extension of APMS contracts, which are also listed in the paper for the reasons given. I'll leave it at that, Pam. So the first bit for information only, the second 2 for agreement.
Okay, I noticed that we haven't got anybody from the APMS contracts here today, so there's no conflict of interest, but there is a conflict in terms of the first ask of the paper. Yeah, so the way that I'm going to handle that is anyway, I'm assuming that any GPs on the committee couldn't actually influence that in any way and won't be making a decision on it anyway. So that's how I'm going to handle that. Has anybody got any questions on this? It's ominously silent. It must be the heat today, I think. So can I ask them, can the committee agree to note the updates in respect of primary care commissioning and contracting? That's the first one. Can they approve the recommendations to use the NHS Pathway SMR Live tool for prioritisation and to enable workforce planning? Would you agree with that? And can they approve the extension of the APMS contracts with Northgate Surgery and Cheshire and Wirral Partnership Trust until March 2023? Is everybody happy with those? Yes, I'm seeing lots of nodding heads. Thank you very much, Chris. I'm afraid it's you again though, isn't it, for item 2.3? Well, I'm not afraid it's you again, it's just you've been busy today. So can you take us through Garden Lane practice boundary changes, please?
Yeah, so committee members may be aware that practices at any time can apply to change their boundary. That's the boundary in which they are able to register patients from into their practice list. This has been through the usual contracting route of the CCG through the primary care officers, and has been to the usual stakeholders, which are neighbouring practices and the LMC. And you can see we're recommending a position for the reasons given in the paper for the committee to agree this extension, not least because it actually increases the practice area rather than decreases it, which is actually a good move for patients. So neighbouring practices have been consulted on this and are happy with that position. So I'm recommending that the committee agree and sign this off.
I knew, Chris, from this though that it was the practice boundary was made smaller, and that actually didn't come to the committee, did it, when that was approved? And but they're just going back to their old boundary, are they, if you like?
That may have been before the single Cheshire CCG, so we're treating it as a new action. So that may very well have been the case. But regardless, I think it is a good news that any practice extends the boundary because it gives more choice to patients. So hence me recommending the approval.
Has anybody got any questions on this, Chris? I've got another one that's, I'm sorry people can't access this, but when you look at the map, there's a tiny, tiny bit of Blacon that's missing. Is there a reason for that?
It may be just the way that the papers have come out, because it is quite difficult to get the maps onto the documents. So I will double check, Pam, but I think that's just the way the maps appeared. We haven't inadvertently cut half of that area off.
A little piece of Blacon, yeah. There just seemed to be a few roads that were missing. So if you could just check that out for me, Chris, that would be great.
I will check, yes.
Okay, so
sorry, Cram, can I ask a question, please? I've put in the chat. I'm not sure if the chat.
Sorry, Dan.
No, it's all right. It's fine. I just sorry, it's Dan Howcroft, the secondary care CCG member. Having read this, obviously a lot of the change seems to be because of the change in demographics of the student population. Are we confident that when if the population comes back, we're not going to have another situation where they are trying to reduce their boundary again? What reassurance have we got that this is because we don't want to be flip-flatting between the sort of boundaries depending on the student population, really?
No, that's a good question. No, we support practices to maintain usually a stable practice boundary because that gives a sense of known to the local population. So Dan, we wouldn't want to support a position where the boundary is going up and down. That wouldn't be a usual position for us. So it's a good point. And yes, that's usually how we approach it, that the change is there for certainty rather than just a temporary position.
And are they aware of that, I guess? Are they,
yes,
you know,
they should be, yes.
Thank you.
Thanks. I think that point was made by another practice as well when you asked for comments from them. Thanks. Has anybody got any other questions? Oh, Leslie, you've got a question.
No, this might be a silly question, but no, just some practices obviously can request to actually have patients out of area. And obviously that is another option, I suppose, for Garden Lane. I assume that that's not something that they wanted to take up. Just gives patients choice if they work in a particular area but live somewhere else. So I don't know whether they have that in place. Certainly we do in our practice area. So just something to bear in mind, I think.
Yeah, I'd have to check whether they are signed up to that enhanced service. So there is a enhanced service where as Leslie says, practices can sign up patients that are out of area. I'm not sure whether this practice has or not. And of course, practices are free to continue that registration. But actually, given that choice for patients is always something that the CCG gets a lot of information asked about, it's a preferred position that the boundary is looked at as well. So we will double check, Leslie, to see if that practice is signed up to that scheme. But that is something that practices can offer, yes. Probably given the number, they prefer to do it as a boundary change.
Anybody got any more questions? No. Okay, so are we happy to agree the recommendation that we approve Garden Lane Medical Centre's application for a change to their patient catchment area? Everybody's okay with that? Lots of nods. Lovely, thank you very much. So we've approved that. So now we're going to move on to item 2.4, which is the primary care estates update. James, can you assume everybody's read the paper? Just point us to the pertinent things in it for us, please. Thanks, James.
So, this paper has been presented to our primary care estates meeting and has been reviewed by members of that group who are, from a strategic NHS point of view, They're also NHS England, as well as colleagues from the LMC. The paper is really just trying to place a unified policy in that we will be able to measure the level of need in premises. Really, we have a exercise that is just concluded called the Primary Care Data Gathering Exercise, and it's a national exercise that's been going on since last summer, but was curtailed because of COVID during the winter months. And we will be getting reports out that we can then apply a benchmark exercise to each of the practices within Cheshire. This was originally carried out at East and West, I believe, but never at South and Vale. But obviously, as we've mixed all the practices together, the priority at West might not be the priority for the whole of Cheshire. So it's just going to give a fair analysis. Obviously, as we get requests for improvement grants, we'll be able to measure the benefits of that through a scoring matrix. And again, when we have bigger investment proposals, larger extensions, maybe new builds, we'll be able to again measure them in a uniform way, so everyone is going through the same process, really. So it is just a template. It's just trying to create a uniform approach to dealing with the estates throughout Cheshire.
James, I'm noting also in terms of conflicts of interest, there's a potential tenuous future conflict, maybe from any GPs who are here today who might be considering extending their practice in the future. But this is about how we go about doing this. So has anybody got any questions? Just let me look. Neil.
It's a comment rather than a question. Clearly, I've seen this as it's iterated through the estates group, but I know that there's been a lot of positive feedback both from William Greenwood from the LMC and from the NHS England representative on that group about the way that this has been developed, and it's almost seen by NHS England as an example of good practice that others could learn from. So I just wanted to say well done to James and Lucy and team who've worked really hard with colleagues in pulling this together. I know we've been asking for it for years, and we finally have got something that we think might allow us to better evaluate different needs and schemes in primary care, and we've all probably got memories of things that we might have done differently if we'd had this in place a few years ago. So well done, James and team.
Anybody got any other questions? Wendy. Oh, I think I might have missed someone before Wendy. Hold on. Paula, you've got a question first, sorry. Oh, lots of people have got questions. Sorry, my system's not keeping up. Hold on. Next person, I'm going to Simon, then Linda, then Paula, and then Wendy. Simon.
Thanks, Pam. So my question really related to how practices will be able to access the information that's available, because obviously everyone's going to be really interested to see where they sit on this matrix. How is it going to be publicised to the practices?
Initially, we need to do the benchmarking exercise, will be that sort of baseline exercise, and we're more than happy to send that out within a GP sort of estates newsletter. We are intending on sending a newsletter out that will just be aimed at estates developments and items of interest. I think we send correspondence out at the minute, but it tends to go to the lead GP. So I think the idea was William and his team were going to help get that circulated to all members of the medical staff as well as practice managers, but it will go out probably once we get the data completed. It's going to be September, October. So the latter part of this year, we'll be able to get that benchmarking exercise out, and then obviously there'll be applications on how to submit forms from there.
Oh, right, because I was getting the impression that it was ready to go, as it were, because the end of the year is quite a long way away, isn't it, for practices that are all desperate to find out if they've got any chance of improvements.
We're still waiting for the data gathering exercise to be summarised. It only finished last week, they'll be pulling the data together. Unfortunately, we have a small number of practices that haven't contributed to that, so we are just trying to do those chaser emails to understand why they've not contributed. But we will get it out to
the end of the year.
I think it will be well before then, but it relies on getting the basic data available so we can analyse that and input it into our scoring matrix.
Okay, thanks.
Okay, Linda?
I was just going to commend the policy. I think it does really improve our transparency and consistency in the decision-making process and prioritising things. So yeah, I would sort of echo Neil's comments and say really, really good piece of work. Thank you.
Thank you. Awesome.
Paula?
Thank you. I think it's really helpful, and so thank you. Can I just pick up on point 10 around the additional roles reimbursement scheme? I'm really pleased to see mention of the scheme in there, but it does allude to the fact that, you know, there remains concern about the ability to house people in terms of additional roles reimbursement scheme. So I guess for me it was just about having a point in our mind at which we would want to review this as we become more clear about not only the space but also the facilities as well that will be required as part of additional roles reimbursement, because it might not be that people require the same type of premises or facility. And I just wanted to put a place marker there, really, to say that, you know, new models of care mean that we will have to be alert to reviewing this. Now, I know all policies always have an early review date in them, but as this is a new policy, and it does, it says our significant concerns remains the capacity, and that's quite unusual language for us to use in a policy without us then making sure we've got a place marker to get back into it. So I think the transparency of placing it in there is highly commendable. But I guess I'd just be looking for a point at which we come back and have that conversation as we gather more clarity and certainty on those roles. And the second point was in Appendix B on page 13 of the paper. And it's at point G, and it says the CCG expects that proposals will move through the stages in a timely manner, and anything that takes more than a year will require resubmission for renewal. I guess it was just about making sure that there's enough capacity to do that. You know, so we've got a really solid policy and approach to considering schemes and processes now. But if we are going to have to review, a number of us have been involved in a number of cases that have come backwards and forwards to this committee, and sometimes we have exceeded the 12 months. And I do understand we sometimes have extraordinary circumstances, but it really was for me about, if this committee is not meeting that frequently, how do we make sure that we're not part of the holdup? Was something I just wanted to play into that. So thank you.
Thank you.
Anybody want to comment on that, James or Neil?
I think we would need to look at each application on a case-by-case basis. Clearly, something that is a whole. If it's an extension, obviously there are constraints that are sort of beyond our control with things like planning and design, and clearly anything to do with build. So some schemes are very short-term sort of based, in NHS England offer a premises improvement grant process. Other schemes, and we've had some that are bouncing around and probably been going around the houses for the last 15 years. So we are still attempting to try and bring those to fruition in a managed way, and we've had some papers presented in the last few primary care meetings about that. So I think it will be on a case-by-case basis, but point noted. Thank you.
Wendy, you've got a question.
Sorry, there we go. I'm just interested in, I mean, it's great that we've got some consistency and an approach, and I think that's great for the business as usual side of it. Given that things are changing, and obviously this is a national approach, so we will be consistent across Merseyside as well. I was just interested in 4.2, where it talks about the health and wellbeing hubs. and obviously these would be out with some of this process. And then that struck me that actually there could be changes in the community-based approach generally in the future, where actually large investments may be made in a locality which pushes this to the back burner. How are we going to make sure that it looks like equity of provision for those people who are desperately trying to refurbish and upgrade their premises, but are not looking for this great expansion, and maybe somebody down the road who've got rather good premises, but actually are ideally located for this great big hub or community-based approach? Are we actually going to be able to manage that, or am I maybe looking too far into the future here?
I think this is just a sort of a stake in the ground at the moment. This will clearly be a flexible policy that will adapt to NHS England sort of guidelines. We've already heard about Cavell centres that were integrated social and care hubs. That was a trial or a trial that they've got 6 pilot sites throughout the UK. There is a summer spending review. We have got a lot of data coming out from the national gathering, the data gathering exercise, and I think this will determine a more concise direction from NHS England for the future of primary care. Clearly, investment has always been around the shiny new hospitals that cost a significant amount of money, and I think little consideration has been done regarding primary care. I think we're also waiting for updated premises directions that will give us a better indication on which way we can go, because clearly there's limited funds available. NHS England will also have a desire, and it's a long-term desire, 25, 30 years, to take all of primary care out of the sort of private ownership that they are, whether that's with either GPs or with third-party developers, into a sort of a public sector ownership. They've excluded how they're going to fund that, because clearly that's a huge amount of money to take on those type of assets, but that is a direction of travel, but they just need to sort of add some more weight behind that. So hopefully we may get that at the end of the spending review for the summer.
Thank you for that. Are there any more questions from anybody? No, okay. We're asked therefore to approve the estates investment policy and added value test. So can everybody agree with that? It's a good piece of work. Yeah, thank you very much. So we've approved that. That's lovely. Okay, so let's move on to section 2.5. Which is about the Enhanced Service Review Progress Report, which Tanya's going to talk to us about. Also, again, noting conflict of interest with respect to GPs that are in the meeting today. I'm quite happy to take questions on it at the end from them, though, or comments if people would like to do that. Tanya, over to you.
Yep, hi everybody, it's Tanya Jeffcoat-Malin from the primary care team. I'll just very quickly summarise the main points of the report. You've asked to receive regular updates in terms of the progress of the local enhanced or local discretionary services review. As you can see, progress has been made. We're still working with our stakeholder group to review all of the local enhanced services that we currently commission from our GP practices across Cheshire. And on the advice of the stakeholder group, which is made up of GP practice members, ICP members, CCG members, and also the LMC, we have gone out to our GP practices to ask them to have a look at the local enhanced services that we commission and prioritise based on clinical need as to which are the services that we do need to continue to commission into the future and will form the basis of our new Cheshire-wide local enhanced service. We've also asked them to review the delivery model. So do some of these services need to be delivered at practice, PCN, or even a larger scale level? And we've also asked them to add into that table any services that they are currently delivering that still need to be delivered and commissioned into the future, but are not currently contracted or funded. So the GP practices received that paper, I think it was 2 weeks ago now, and we've given them until mid-August to email back to us and prioritise which of those services should form the basis of the new contract. Just yesterday, we found we were having a few queries and questions that were coming back from GP practices. So the primary care team has recorded a talk-through video of that paper that we intend to send out to our GP practices to really give that kind of interaction and support the consultation process and allow GP practices to really feel that they can add into this review essentially. At the same time as that, parallel to that, and part of the primary care team are also turning this prioritisation paper into something that is public and patient friendly, so that the sort of patient population of Cheshire are also able to feed into this review and give feedback around what they feel is a priority that we commission from our GP practices. Included within both of those papers is the data around what our patient prevalence and what our patient needs are. And as I say, my member of staff who is working on this piece of work is going to be linking closely to the PPGs and also Louise Health Watch to get your advice on how we make this consultation exercise with our patients as useful as possible and we get the feedback that we need. So essentially that's where we're up to. Like I say, the responses from those prioritisation exercises should come back mid-August, and as per the recommendations of the paper, what we may wish to do is actually implement some parts of that new contract where possible in Q3, with the hopes to implement the entirety of the new contract from April next year when we become the wider integrated care system. And therefore we've asked within the paper whether it might be possible, as those reviews come through, that we may need an extraordinary primary care commissioning committee possibly taking place towards the end of August or beginning of September to approve any of those contract changes that will potentially be implemented if all goes to plan at the beginning of October.
Thank you for that, Tanya. I'm really pleased with this approach because it's bottom up. I was always very worried that it wasn't going to be, and because it is, I'm really pleased. And I'm also really pleased that you're actually taking in, and I would be with my patients and public views on this and involving Health Watch. Has anybody got any questions on this paper? You've stunned us all into silence, Tanya. Sorry, Linda.
Sorry, I just raised my hand rather than typing. I just wanted to ask, is the list of services, Tanya, is it inclusive of all of the discretionary contracted services that we have across each of the previous 4 areas? So does it cover everything?
The master list does. The list that we've sent out to practices doesn't, because some of the historical schemes are not really the ones that need to be prioritised to form the new LES contract. So some of them we need to look at individually rather than considering how they're going to form part of the new contract. So the list of LESs that you see in the prioritisation document here doesn't include all schemes of discretionary spend, but the review and the master list that we're working on in the background in the CCG does.
Okay. Can I just say my name is Linda Risk and I'm the Director of Finance. I'm sorry, I think I've spoken twice without saying that. So thank you. Thank you very much, Tanya.
Has anybody got any other questions? Paula and then Leslie.
Thank you. Paula, Director of Quality and Patient Experience and Safeguarding. Thank you, Tanya. It really builds on the point that Linda's just made, which is in relation to the prioritisation really, and just looking for perhaps a feedback really on the consensus about those that we've prioritised. I understand the enormity of this task and trying to get everything right all the time could actually cause us to delay. So thank you very much for the forward momentum on this, and I welcome the idea of that wider consultation and engagement. I guess I was just keen to understand the process that we've gone to make sure that we prioritise those that were most pressing.
you want me to come back on that, Pam?
Yes, please.
Yeah, so in terms of the prioritisation process, what we've asked of the GP practice at this stage is to prioritise based on clinical need of the patient population. It's difficult because, you know, you're aware conflicts of interest, etc. There are lots of pulls on, you know, the GP's thoughts around which of these areas should be a priority, but we've asked them to do that based on clinical priority, and we've included within that the population needs assessment for each of the PCNs. So we've asked the GP practices to look at their population needs and then prioritise based on clinical need of the population, rather than some of the, you know, other pulls they may have on their sort of thoughts around how to prioritise these. So I hope that answers your question, Paula.
Thank you. Leslie, you've got a question.
Hello, Leslie Atherton, a governing body GP. So thanks, Tanya. I can see there's a lot of work gone into this. So my question's around phlebotomy. Just in my old clinical lead role, there's a lot of disparity with how practices were being paid, and I think it's probably even more so now we've become Cheshire CCG. And I suppose how, in my mind, that's going to be quite complex. So I was surprised to see it on the list, really. Obviously, as practices want to provide the phlebotomy in-house, it's much better for patient care, isn't it? But it is very varied with the offer. And obviously, we have some practices who utilise the Countess of Chester and other community services that are outside the practice. So I suppose my question is how that, I suppose whether you're looking into those things, and I suppose how that would work on a Cheshire-wide footprint. And that might be something for outside this meeting, so happy to chat to you later, but thanks for that.
Do you want to
comment,
or do you want to take it?
I can very quickly comment. It's a very similar situation for wound care, actually. So there's a couple of you know, situations at the moment where GP practices either in some areas deliver it the entirety themselves, in other areas it's just part, or in other areas not at all. And so what we're doing for those is they're going to have their own individual expert task and finish group made up of CCG programme, primary care and clinical leads, where they'll get their own review individually. So although this paper summarises the review as a whole, for the more complex areas, there will be individual task and finish groups specifically around those areas to draw us to the conclusion of what the future contract will be. So yeah, although I'm sort of presenting to you what looks like a slightly easier situation with the entirety of, you know, this is where the review's up to, there is individual task and finish groups taking forward those complex matters.
Yeah, I suppose it's just being aware of the financial risk that I knew there was definitely one with regards to phlebotomy, and I imagine will be for wound care as well. So just to be aware of that. Thanks.
Neil, did you want to comment?
Yeah, and I realise we're doing the easy bit at the moment, which is the theoretical bit rather than the hard negotiation. So I think Leslie makes a fair point that there's significant risk with all of this work. The comment I was just going to make was around our focus at the moment is very much on services to patients. And by that, I'm meaning we're provider agnostic. So taking the phlebotomy example, we're not particularly focused on whether it's Countess of Chester or a practice who's delivering the service. We're cognizant of giving people local access to consistent high quality services. Again, I know I'm simplifying something that's far more complicated than I'm making it sound, but that's our starting point. It's what services do we need? And then we recognize that the difficult bit comes in, how much is it going to cost and who's going to provide it in individual localities. And we're not expecting that every single service would be delivered directly by a GP practice, when a number of them aren't currently delivered by GP practices for very good reasons. But what we want to ensure is that the patients do have an equivalent level and quality of service wherever they are in Cheshire. So I'm talking with a very blue sky view of the world today, and look forward to the difficult times to come.
Okay, so no more questions. No one's put a comment in the box. Oh, Louise, you have.
Yeah, hi. Thanks, Tanya. I think I'm just a bit concerned about the timescale of this and the desire to involve the public. That makes me a bit nervous. I'm not sure. I don't know if any of this is already underway. I've certainly not come across it. And kind of to introduce it and then to expect there to be, that's my nervousness. I'm nervous that I think it's commendable that you're going that way. I'm just not sure the timeframes lend themselves to that being as comprehensive as you'd probably like.
Tanya, have you got a comment on that? Oh, you're on mute, Tanya.
Apologies. Yeah, that's a fair point. We're currently in the process of working with our comms team to translate the document that you see here into something that is more patient friendly. We're hoping to have that completed where possible by the end of this week, and we'll then be making contact with PPGs, with Healthwatch, etc., to say how can we start to distribute this out, get it onto websites, etc., to start getting that feedback. The feedback we're expecting from the patients, we're not going to go down to the granular level of each of the individual local enhanced services. We think that would probably, cause more questions than answers from patients, because unless you have an understanding of what GP practices already deliver as a basic almost compared to what are additions, then it would be very difficult. One patient in one practice would say, well, my practice do this anyway, without necessarily understanding that that's an additional service that practice is, chooses to deliver, which is different from others. So we're trying to make that as patient friendly as we possibly can, and then we're hoping within the next week or so we want to get it out to the forums to start getting some feedback. But you're absolutely right, Louise, the time frames involved here are really, really short, so we need to try and do that in the best way we can, and if we need to extend it to make sure we get that relevant feedback from the patients and the public, then I think that's what we need to do, because we need that feedback.
Thanks for that, Tanya. Okay, has anybody got any other comments or questions? No. Okay, sorry, my phone's ringing. We'll just ignore it. We're asked to note and agree the action plan for the key areas identified, and we're asked to agree the provisionally schedule an extraordinary meeting. Now, I'm under the impression that some of the funding for this is not within the gift of the Primary Care Commissioning Committee. Am I right, Linda? Yeah. So some of it will have to go to the governing body. So I think we just need to have the debate, maybe not now. We need to have the debate outside of this, whether or not we do this virtually with the Primary Care Commissioning, because a lot of us are already on the governing body as well. So I think we need to work out which is the best governance route for it. But certainly somehow it will come back to this committee. So is everybody okay with that approach, and can everybody agree those recommendations? Okay. Linda, you've got your hand up.
Yes, I'm happy with that approach and the recommendations, but I do think we need to consider the risk of the changes to the structures in the NHS, which we're going through at the moment, and the ability of the CCG to make decisions after a certain point in time, which I think is September.
Right, so that's probably one of the reasons why the timescale is short, I assume, Tanya, but I think we're just going to have to cross that bridge when we come to it, Linda. Yes,
we just need to take that into account as a risk on all projects, I suppose, that we're doing, and that we may need to go through. It's not like a risk that it'll stop it, but we might need a few additional hurdles in terms of authorization once we get to a certain point of the year.
Thanks for pointing that out. Neil, did you want to say something again?
Yeah, it's just in relation to what Linda's saying. We have been mindful of this risk for some time, and Claire Watson had spoken to the ICS, or the HCP as they probably were at the time, in terms of should we continue and do you support this, and there was support for it. I recognise the people she spoke to may not be in post by then, or certainly one's already not in post. So I don't disagree with Linda's point on risk. We are trying to manage that risk as we go along, to avoid everyone's time and taking people along a route that we can't fulfil on. But I think Linda is right, and we need to keep that dialogue going with the ICS throughout this process, so they don't create a delay or block at the last minute.
Thank you.
Thank you. Okay, so with those caveats, we are agreeing to the recommendations in the report. Okay, so we're going to move on now to the additional rows reimbursement scheme. Who's going to take us through this?
That's myself.
Thanks,
so
Lorraine.
I'm Lorraine Weeks-Bailey, Senior Primary Care Accountant. So hopefully you've read through the paper. So it gives a brief overview of what the additional roles is and the part it plays in the primary care network DES. So as you go down, you can see there's around 20-ish roles, which is additional funding which will go into primary care, which the PCNs can appoint to these roles to support the primary care workforce. So if you look at Table 1, Table 1 basically gives an overview of the allocations that were given in 2019-20 and the projections for the next 5 years. So from 2021, it was then done on a weighted list size average. So obviously the bigger the PCN, the more allocation that they were received. So then if we look down, we can see that 9.9 million has been allocated to PCNs for the current financial year. So Table 2 gives an indication of the spend currently. So for April, May and June, where we've got the awaiting claims, that's obviously where we've got PCNs that haven't submitted their claims yet. Just to note, when you compare this table to Andrew's finance table later on, that's just a timing issue. So Andrew's finance paper reports on month 3, which is our quarter end financial position, whereas this is the live data. So this is all of the information of the claims that were paid up until literally a few days before the paper was published. So the variance is due to a timing variance. You can see here as well, so the £9.9 million that's been allocated, we get around 827,000 that can be spent within the PCNs each month. You can see here that there's quite a variation to that. So there is an underspend currently that we are showing. I just wanted to mention and assure that the £9.9 million that's been allocated, only 60% of that allocation sits within the CCG. So once we reach the 60%, we can then claim upon the rest of the funding from NHS England. So NHS England are monitoring this quite closely. So it won't be, if we don't reach the 9.9, the underspend then won't go to the CCG bottom line. It is a case of once we reach the allocation, we then have to draw that down from NHS England. So just to point that out. So then we've got the PCN workforce plans, which is in the table 3. Now that just basically illustrates what PCNs have got in place at the minute, the roles, and what their plans are between now and the end of the financial year. So between finance and the primary care team, we're helping support the ICP colleagues to make sure that we understand what roles they're going to have in place between now and the end of the year. So in the appendix, you'll see a table, which is a workforce template that basically we're hoping that over the next few quarters, they can demonstrate what they're going to spend. So you can see that some PCNs are anticipating that there will be an underspend and some are hoping to maximise and hit their allocations. And that's basically it, if there's any questions.
Okay, thanks, Ray. It just seems a pity to me that we might not be able to spend all this money come the end of the financial year. But yes, has anybody got any questions for Lorraine? No. Stan has. Stan's waving at me.
Yeah, sorry, I thought I'd about to miss my chance. Sorry, I had to step away briefly. I read the paper, I haven't had a chance to hear this summary, so you may have already covered this. But do we know what the barriers to people wanting to use this? Because it wasn't entirely clear in the paper, and I guess it feeds on what Pam was just saying. But why is it not, you think, it'd be the easiest thing to sell in the world? You know, free money to support patient care through third parties. So what are the barriers to people using it or trying to get it?
So there's elements around the mental health advisors. So we've struggled with those. So I don't know if anyone else wants to elaborate on the issues around the CWP appointments, because I think there's probably, Dean's closer to the workforce, I'm closer to the numbers. So I don't know if Neil could just answer that question around the mental health advisor.
Yeah, and I'll let my GP colleagues, who I can see grinning wryly at the question, Dan, who may want to come in with the view from the practice in a minute. The mental health roles, there's been I guess, a delay in terms of some of the national funding arrangements, because it's half funded via this scheme and half funded by the health provider, which in our case is CWP, and that has delayed some of the progress getting that up and running. I think my perspective on what I'm hearing from practices and PCN directors around why doesn't this money just get spent instantly? The first one is about the ability to recruit the staff. So you advertise a post, but can you fill it? Because the workforce isn't necessarily out there, or the quality of workforce you'd want might not be out there. The second bit is, I guess, about productivity, that some of the posts do require an awful lot of support to embed. And when you've got general practice currently struggling to the level it is, along with many other sectors in terms of the sheer volume of work, in the short term, it creates some pain, even though there might be some long-term benefit. So as I say, others may want to come in on that point. I was just going to pick up Pam's point about it's a real shame if we can't spend this, and that is the corporate position of the CCG, that this is a budget that bizarrely we desperately want to spend every penny of, because we can see the real value in getting more capacity. We did have a meeting last week, which was with the clinical leads and the ICP management leads, around how we could work to generate a plan B. So if we're going to have underspends, are there ways that we collectively might be able to claw those underspends together to invest in more centralised schemes which put more capacity into areas of general practice? And we've started working that up, and we want to talk to PCN directors. The challenge we have with that is some PCNs are still very confident that they'll spend their budget, others aren't, and then you get to the debate about, well, if you recruit central staff, it's my we're using, so are you going to target the staff at my area? And it gets a bit more complicated, but we're trying to work through that as we speak, in terms of making sure we maximise as much of this budget as we can as early as we can. But our first preference always remains that the PCNs spend the money on the roles they believe are most valuable, but then we have this plan B sat behind that might limit any potential underspend on this particular budget.
So just so I'm clear, sorry Neil, just so I'm clear, so is the only way that can be the money can be accessed is if the PCNs or practices actually employ people as individuals? Is there no way of using third parties and sort of bringing them in?
Yeah, that was the purpose of the meeting last week, that you can subcontract. You can only employ a specific roles which are nationally defined and mentioned in the paper, but you can do it through a subcontract arrangement. So what we were talking about was whether we could use some of our larger providers to recruit the staff, and they may find it easier to recruit them, and then they provide that workforce to support general practice. So we're looking at every which way we might be able to invest this money in, conscious that a likely winter for general practice and the wider system is looking challenging, shall we say, at best.
Paula, did you want to come in?
I think Neil's probably answered my point, really. I mean, clearly, you know, it's uplifting in terms of there being the investment there, the recognition, you know, of the expansion of those clinical roles. I guess my reflection was it's already a limited pool of people who are undertaking these professional roles, and what we don't want to do necessarily is just kind of move people around and leave gaps elsewhere, really. So unless you take a wholesale workforce plan approach to this, and we go for a longer approach to this in terms of numbers of people that we require in our workforce returns to Health Education England and the number of places that are funded, which I think has surely got to be the strategic direction in which we go. But I think in terms of thinking about resilience, where you have small numbers of staff working in smaller pockets, it will always bring risk. So I guess I was just going to the point of how can we build in some resilience, some sharing, some workforce cover, which I think, you know, supports the ability to recruit if there is some wider offers and wider benefits for staff. There will always be people who are really attracted to working very locally within an individual practice, And I think that's really, really positive. But there will also perhaps be a cohort of staff who might want to work in a wider pool, and I think linking to some of the existing providers may add value. Although just to try and stop this moving of people around, and to take us forward to a space that feels collaborative rather than perhaps competing for the same staff. But it's great to see this level of investment and money available. But I do think there is a workforce piece here rather than it's as simple as trying to find people with these special skills to work. And then the second thing really, just to link it back to the paper that we've seen earlier from an estates perspective. We already saw earlier that they made mention of the challenge of trying to accommodate enough people. And I did wonder sometimes if you're sharing resources, whether maybe it might allow you to flex rooms and accommodation. For example, in neighbouring practices, if people needed different facilities to deliver different clinical skills and expertise.
Thanks for that, Paula. That's really useful. Has anybody got any more comments or any questions? No. I note that you're intending to bring an update to the next Primary Care Commissioning Committee, Lorraine, so that's good, thank you. The committee therefore asked to note the contents of the report. I'm not going to go through all the recommendations because everything in there is just a recommendation to note. So can we all agree that we can just do that? Lovely, thank you. The next point is 2.7, which is extended access update, and that's back to Tanya.
It is, yes. Are you ready for me to go, Pam?
I am, thank you.
Lovely, thank you. So again, I'll just quickly summarise the main points of the paper, hoping that most people will have read it. As we've noted within the paper, and we noted within the paper that we brought last time, at the moment, the PCN DES, where the extended access sort of funding and the extended access requirement to move that into PCNs has been delayed, and that's likely to be launched in practices in April 2022. But in the meantime, CCGs are asked to work with any PCNs who have determined that in advance of this date, they would like to start delivering extended access from within the PCN. And quite a few months ago now, we were contacted by the PCNs in West Cheshire and their primary care provider, Primary Care Cheshire, to state that they would be interested in starting to deliver extended access through the PCNs from October this year. Conversations have been ongoing. However, we have hit a number of challenges that we are currently working through. The first one is that the PCNs over in West and their primary care provider were hopeful that they would receive what they expect to be the full extended access funding that will need to be transferred over to the PCNs from April next year. Now, the national specification hasn't yet been released, but they are expecting that that amount will be £7.45 per head of population. Now, some of that funding is already within the CCG, as we already commission an extended access service across the patch. However, in West Cheshire at the moment, that is being delivered by Cheshire and Wirral Partnership. And we have had conversations with Cheshire and Wirral Partnership to say that potentially they would be stopping delivering that service from October as that is transferred into the PCNs. However, the funding that's currently provided to Cheshire and Wirral Partnership to deliver that service is significantly less than the £7.45. And that is because that budget at the moment, through historical arrangements through the Prime Minister's Challenge Fund, is being utilised for some other services that, although are not traditional sort of primary care and are not extended hours services in that sense, are supporting pressures within primary care. So namely, that's step 4, mental health first, that's physiotherapy first, and that's wellbeing coordinators. So at the moment in this financial year, the CCG isn't in the position to be able to transfer the entirety of that budget over to Primary Care Cheshire, and would only really have the amount that we currently fund to Cheshire and Wirral Partnership to transfer over to Primary Care Cheshire and the West PCNs. Now, the West PCNs and Primary Care Cheshire have asked us to consider transferring the full amount of the pro rata half year £7.45. However, doing that would obviously cause a significant cost pressure to the CCG, as we would be committed to continue to commission and fund the additional services that I've spoken about, Physio First, Mental Health First and Wellbeing Coordinators for the second half of this year. So there will need to be a decision made, but we're probably not in the position to ask for that decision just right at this moment. There's still some more information we need to gather around the actual costs of delivering that service from the PCNs, and also around some of the difficulties around getting that service set up, which relate to, there's some staffing issues, there is some issues relating to IT and some issues relating to pharmacy, as well as the funding issues that we really need to get a good understanding of before we can bring the paper through the governance process and through Primary Care Commissioning Committee to ask for the decision to be made as to what funding we do transfer to Primary Care Cheshire and the PCNs in West in year. However, we have notified Primary Care Cheshire that that funding is likely to be the amount that we currently fund with CWP, which is less than the pro rata £7.45 per head. Now, Primary Care Cheshire have obviously indicated to us that that is a concern, and that is going to cause them some difficulties due to issues around, engagement with the PCNs and readiness to deliver. So in terms of CWP potentially winding down their operations and the PCNs trying to wind up their operations and recruit additional staff, and that will obviously raise some risks to them if they have been making the assumption that the full funding is transferred rather than just the amount that is currently being paid towards Cheshire and Wirral Partnership. So we will need to ask for probably an extraordinary Primary Care Commissioning Committee once we have managed to gather the entirety of the information we need, including the costs of the PCNs delivering the service, for Primary Care Commissioning Committee to make the decision around funding transfer in year. There is obviously a risk that we need to do that ASAP because of the staffing implications for the PCNs and Cheshire and Wirral Partnership and Primary Care Cheshire that potentially could impact from the 1st of October. It should also be noted that we need to consider what we're going to do around these services in the future. So as I say, this year we are committed for using the extended access funding to commission and fund wellbeing coordinators, Physio First and Mental Health First. However, we will need to have a conversation and have a discussion from the 1st of April next year, when this funding is transferred to the PCN, how are these services potentially going to continue to be commissioned and how are they going to be funded? Is that going to form part of the CCG's commissioning responsibility and part of our baseline, as it were? Or is that to be transferred over to the responsibility of the PCNs with the budget that is moving over and the sort of additional role scheme that some of these roles link into? Like I say, at the moment, we're not really able to ask you to make a decision because there is still some further information that we need to gather before you can make decisions around both the this year financial implications and also the commissioning implications from the 1st of April next year with those additional services. However, this is a complex issue. It does pose lots of risks on both our side as a CCG and also the provider side. And obviously, the key in our mind is making sure that continuity of provision of services for patients, both in terms of extended access and in terms of those additional services that are providing added value to patients and are improving outcomes. So that's a summary of the paper and the position as it stands currently.
Thanks, Tanya. That's clarified things for me a great deal. I wasn't sure what was going to happen to the additional workforce, and you've actually said that you're not sure either, so that's really useful. I'm talking from the 1st of April. Leslie, I'm aware of the fact that you're a GP in the West and therefore might be slightly conflicted, but you've asked to have a comment. And basically, because we're not making a decision on anything, and this is still in terms of consultation, I'm quite happy to take that comment today.
It's mainly a comment about current service provision, really, and making sure that it's fit for purpose for patient access, just because it's very variable across the patch, and it may be the case that it's variable across Cheshire as well. Just that you know, sometimes it's a bit hit and miss whether anybody has turned up for sessions in the past, and whether there's actually been provision, and whether the CWP has still been paid for that service despite actually not providing it to the full. So I would have concerns about or would want reassurance about that provision up till April. And obviously I know it's not a decision with regards to sort of who has that contract at the moment, but just that whoever has it, that the patients benefit from it and that it is fit for purpose, you know, whatever we decide to do. Thanks.
Andrew's got a point, and then Linda.
Hi, it's just a comment on something that Tanya actually made on the week, that just for clarity, the original funding that came out of the Prime Minister's Challenge Fund, I believe West Cheshire, what was West Cheshire CCG, applied at that point in time to use the money slightly differently rather than spending it all on extended hours or whatever. So although we have commissioned additional services out of that money, I think it was done correctly and legitimately and things. It wasn't like the CCG was funding other pressures by using that money. It was using that money to fund services that were key to helping primary care as a whole provide their own services.
Thanks, Andrew. I was in the West, and yes, that's my understanding as well. Linda, did you have a point to make or question?
I've got a couple of questions. Is it our option as to whether, I've lost Tanya, there they go. Is it our option to whether we allow the changes to the extended access scheme to move it into the PCN? So can we say no?
My understanding is yes, we can say no. My understanding is that we are asked by NHS England to support PCNs that want to move ahead in advance. However, this is in advance of the national specification. So I don't think until that national specification is released, I don't think we are mandated to make that transfer. Although, as Leslie says, you know, there has been some issues with the current provider, and we are getting assurance from the new provider, if that happens, that those issues won't be there for patients going forward. So it should be an improvement for patients going forward if that transfer is made. It's just whether it's financially able to happen in year, and there are also some logistic issues, as I've listed, that may make it happening in year quite difficult.
Yeah. So have we given, I mean, there's a whole load of issues around contractual notice, etc., with CWP, with the provider of the additional services, etc., which we need to make sure that we don't fall foul of as well, because obviously CWP and the additional service provider would probably require as a minimum 6 months notice and possibly 12 months notice. So I think we ought to be probably aware of that as well. And I suppose, again, the risks around decisions and the changes to the ICS, we also need to be aware of that as well, because obviously what we're proposing potentially here is to increase the £600,000, I think it is, additional cost to the system when we are already in a difficult financial position. Obviously not within the primary care budgets, but within the other budgets for the CCG. Thank you.
Linda, Tanya, do you want to comment or?
Yeah, just in terms of the contractual point, so our understanding that the additional services, so wellbeing coordinators, physio first and mental health first, is currently running on an implied contract. We haven't got an up-to-date contract in place. However, we're obviously aware that through those even implied contracts, there are contractual notices that we need to look at. In terms of the CWP service delivering extended access at the moment, there is already notice in place for that service to stop as of the 1st of October, and having had a conversation with the service manager at CWP today, they are currently consulting with staff and have made plans to stop delivering that service from the 1st of October. So if there is going to be any change in those plans, we need to be doing that ASAP.
So we give a notice on a service when we don't have another service to put in place?
My understanding now, Neil obviously might want to jump in here, but my understanding is it was the other way round. CWP gave notice on us that they no longer wish to provide it.
Yes, I suppose if they're being paid £600,000 less than we're proposing to buy the other extended service, I suppose they perhaps wouldn't want to deliver it. Yes. Thank you.
Anybody got any other questions? Lovely, thank you. So we're asked actually to note the report, asked to note the actions currently being taken.
Simon does.
Oh, sorry, didn't catch you.
Sorry, Pam, I've put something in the chat box. My question really, Tanya, was that the Primary Care Cheshire have been working on the basis they were going to have a certain budget available to them. What was the reason that they were working on that? Had they been led to believe in their discussions earlier on last year with the CCG that would be the case or not?
I think they were working on the basis of the national specification. I think it is understood that the £7.45 is likely to be the amount that's transferred as of April. Obviously, that national specification has now been delayed. What we don't know is what is required to be delivered within that specification. It's very unlikely, but it could say that wellbeing coordinators are a part of that specification and need to be delivered as part of the £7.45. That's not likely, but that is a potential. So whatever we set up this year will be doing in advance of knowing actually what is going to be required in that national specification from April. So that obviously causes a risk for us as a CCG, but also for the PCNs. You know, they're going to be recruiting to the roles that they believe are going to be a part of that national specification and believe will need to be recruited with that £7.45 without actually seeing the detail, without that being released. So it causes risks for both sides, really, you know, doing it in advance of the national spec. But the £7.45 is what's likely to be transferred from April next year. It's just we don't know what's being asked of for that £7.45 at this stage.
Thanks.
Sorry about that, Simon. Okay, so can I move us on then with the recommendations? That we note the actions currently being taken with the extended access service. Oh, who else? Sorry.
Sorry, I had one more question. Do we have to have an extended access service? Because that would be the other option, is not to have one. But you're saying we do have to have one of some description.
Yes, I mean it is a requirement, and we have a required number. I mean, Sarah from NHS England might want to come in at this point, but we do have a required number of hours that NHS England ask us to provide for the extended hours service, and we do have to report on providing those numbers of hours.
Sarah's nodding her head. Is that so, Sarah? I remember something about hours, but yeah.
Yeah, that's exactly right. Tanya is right. Yeah.
Okay. Chris,
Thank you.
You've not got your mic on, I don't think, Chris.
Some would say that was a good thing. Yes, just to back up, it's a requirement under the DES, and the DES is nationally directed, so it is a requirement to have that service under the DES.
Chris. Anybody got? Oh, Leslie. Leslie's put in the chat box, what happens if there is no one to provide the service?
So I can answer that. So Sarah, I'm hoping Sarah will nod. The CCG have to ensure there is provision. Is that correct? So Sarah's nodding. So there you go. The answers are correct. So we would have to commission and make sure that there was provision.
So it could be you could maybe have to bring someone in from outside of the area to provide it, something like that. If that
possibly,
happened.
but because it's a directed part of the PCN DES, which is basically all or nothing in a way, then we would be interested to understand PCNs who aren't able to provide it. But to be fair, that's a conversation that goes on. It's difficult to give you a point in time now.
Okay, thanks. I think that's maybe something we'll leave if people are okay with that.
I think Leslie just had a hand up. Sorry, Pam.
All right,
No,
Leslie, do you want to come back in?
I think there is an appetite, obviously, from April, but if you're providing a lower offer, from October, then it may be that Primary Care Cheshire decide not to take up that offer and to wait until April, and then you've got a gap in your service provision for 6 months. So how are you going to, I suppose, provide that care for that time? So that was my point.
So Pam, just very quickly coming back on that, as I say, I've had conversations with Cheshire Rural Partnership today, just to make them aware of the potential gap in provision, to see if there is any way that they could support extending the existing service, if there is a gap. But I haven't had, that's very, very early discussions from today, so I haven't got any assurances either way at this stage.
Thank you. But certainly, whatever, this is going to come back to the committee, either virtually or at an extraordinary meeting, which is looking more and more likely that we're going to need to have in August or very early September. Okay, thank you, everybody. Right. I'm going to go back to the recommendations again. I'm determined to get through these. That we're asked to note the actions currently being taken by the Extended Access Service, that we're asked to note that once a preferred approach has been made regarding the service in West within this financial year, that's if there is one, that the committee will be asked to make the decision on that, and that once a preferred approach has been developed, then the Primary Care Committee will be updated. So there will be something coming back to us at our next meeting, whenever that is. If it's got to be an extraordinary one, then so be it. Okay, I'm going to move us on now to item 2.8, which is Lorraine, which is the finance update. Lorraine.
It's actually Andrew.
Yeah. Sorry, I'm Andrew Whittingham, Associate Director of Finance.
Sorry, Andrew.
Hi, in light of the other papers we've received, I purposely kept this paper short and sweet, and just to give everyone a quick update to the month 3 financial position. So this is just really for noting. Obviously, you're all aware that the NHS is, we're being funded differently, particularly in this year. We've currently got a budget for the first 6 months of the year, which we refer to as H1. So the CCG is currently attempting to operate within that. Within that budget, there are costs that fall inside that envelope, and there are costs that fall outside that envelope. So in relation to primary care, this includes things like vaccination costs. So if you look at and this, just to give some context, the CCG is forecasting a break-even position for the first 6 months of the year for costs that are inside the envelope. Costs that are outside the envelope will obviously be funded separately. Just to give an update on sort of the local primary care, obviously the table is showing a current deficit of £556,000 forecast for the first 6 months of the year. However, 578,000 of that is in relation to vaccination costs, which will of course be funded outside the envelope. So currently our local primary care budget is in a break-even position. Moving on to the delegated budget, again, as you all know, that will be a national allocation, and obviously national contracts that accompany that allocation. The CCG that have always had a slight pressure in that area due to the contracted amounts being slightly higher than our sort of regional allocation. So as you can see, there's currently a budgetary pressure of £300,000 for H1. And obviously, we will attempt to mitigate that where we can if there's any slippage in other areas, but generally that is forecast to overspend. Just the only other thing to note at this stage is that we haven't mentioned any of the papers. Obviously, there is the COVID capacity fund of 1.497 million, which is currently being transacted to practices over the first 6 months of the year, and all those figures have been included within our budget and within our expenditure in the tables above. So really, it's just to ask if anyone has any questions or if there's any comments on the financial position.
Has anybody got any questions? Simon. Simon's waving at me. Simon.
Thanks. Yeah, just a quick question about some of the underspends, really. There's 140,000 underspent on PMS, for example. I was just wondering where that comes from. And then other GP services as well, 230,000.
Yeah, so thanks, Sam. So you know, we set the budget based on in terms of delegated, based on the allocation that we receive. So there is some element where we are estimating our expenditure in those areas. Now, normally you would expect, particularly around the contracted sort of general practice GMS and general practice PMS lines, you'd expect that to be fairly accurate. But obviously, you know, like with anything, you know, you're never 100% sure on what those figures will be based on practice allocations and practice sizes, etc. So there will always be some slight variance to those budgets.
Answer your question, Simon?
Yeah, sort of. I'm just wondering what we're spending on PMS stuff at the moment, because I thought we'd phased most of it out.
Yeah, there are obviously still some residual sort of residual practices that are receiving PMS.
That answer your question, Simon? Yeah, okay. Has anybody got any other questions?
I can provide you some information outside of outside the meeting if you'd like to understand it better.
Yeah, that'd be great if you could. Thank you.
Thanks for that offer, Andrew. Thank you. Okay, I haven't got any other questions in the chat box, and no one's waving at me that I can see. So can we just note the contents of the file? Oh, Linda, sorry.
I was just going to say, in terms of APMS contracts, we obviously have a number of those with CWP, and we've just extended them all to, I think, April 2023. So those are presumably the line in the finance budget, which is for APMS. I'm not going mad, am I? We have just extended them. Yes, thank you, Lorraine. Thank you for nodding. So yes, we have already extended those. So we may not have PMS contracts, but we have APMS contracts, and they're different.
And Tanya's also put in the chat box for me that there is a future paper coming to the committee about PMS funding at a later date. Neil, you want to come in?
I'm not sure if it helps. I might be misunderstanding Simon's question. I'll answer Linda's first. There's a number of APMS providers. It's not just CWP, so we have others. Just in terms of PMS, just as a point, I think that the thing we've phased out, Simon, is the PMS premium, but some practices chose not to convert to a GMS contract. So they're still on a PMS contract, but they're not receiving any premium. So I don't know if that was what you were asking about, the premium, or whether it was the PMS bit, but
it was just an overall. I think there are some PMS premiums still floating about.
But Andrew's offered to actually talk to Simon outside of the meeting, so I'm proposing that that's what happens if everybody's okay with that.
Perhaps if we could put it in the next finance report, a bit more detail about APMS, PMS, and any premium, so that it's clear for everybody and transparent.
Yeah, I'll pick up that.
Thank you. Thank you both. That's lovely. So can the committee agree to note the contents of that report? Yes. Good. I'm conscious of the time. We're well ahead of ourselves. I don't like to say this, 2 items from the end of the agenda, but I'm proposing to carry on through, and then we've got quite a nice break before the part 2. Is that all right with people? People still? Okay. So, Kevin, over to you for the primary care ICT update. I can't see Kevin and I can't hear Kevin. No.
He was definitely here before.
was here before, unless he's, for some reason his system's dropped out. Shall
Which
we,
would be rather ironic, wouldn't it, if the ICT paper couldn't be delivered because the ICT leads.
shall we do the primary care quality report and then go back to Kevin? Yes, is everybody okay with that? Katie?
Yeah, that's fine. Looking on the sidebar, it does say for Kevin that he's offline at the moment, so there may be an internet connection problem there or something. Okay, you happy for me to go ahead with my paper then?
Yes, please.
Thank you. So I will give you some highlights from the paper itself and include some updates as I go through it, bearing in mind that this paper has already gone to the Quality Committee in June. So this is the same information that was shared with that committee, and therefore some of the timelines and the dates are slightly longer than we would possibly like in an ideal world. So running through the paper itself, an update on childhood immunisation waiting lists, which was one of the actions from earlier on that we discussed. Since our last primary care committee, I've been working with CHIS, which is the Childhood Health Immunisation Service. They were actually already ahead of we've been working with them already about reducing the waiting lists. So they've been contacting some of the practices, and we have got an improving picture. We've still got 7 practices that we've got a level of concern about, but each of those has now engaged with us and is reducing their waiting lists and put action plans in place. Just to give a sort of broad update in terms of numbers, back in November we had just shy of 1,700 children on waiting lists for childhood immunisations. As of June, that was down to 819. So we've nearly halved that waiting list. And that is from a number of factors. There were a lot of issues with data, and the accuracy of data on the childhood immunisation system wasn't accurate. They have now implemented an automatic data extraction, and that has resolved a lot of the issues. So we're now working through those real-time children that are waiting for their immunisations, and I'll obviously bring an update to our next committee on that. In terms of cervical screening, sorry, can you hear the noise coming from outside? I've got the window open and a child has obviously fallen outside the house, so she's screaming. Sorry, I'll try not to be distracted by her. Next on the list was cervical screening. So we had a large number of rejected samples that are reported in this paper. That we've continued to monitor that situation, and we have definitely got an improving picture. There was twofold really. There was a number of vials that were passing their expiry date whilst waiting to be examined in the lab, and that was due to a number of factors, but that has now resolved, thankfully. We're keeping a close eye on that, and we have sent comms out to primary care and to the nurses themselves to ensure that they are aware of the lab's new zero tolerance policy, so they won't accept any samples that don't have 3 or 4 identifying patient IDs on them, or that are in any way out of scope for the screening policies. There is still an issue around the wait time for results in the cytology lab. It has improved in that 85% of results are now back within 14 days. They are generally for HPV negative results. There is still 12% of samples that are taking up to 42 days to report on. So that is a situation we need to keep closely monitoring. Next on the list is an update around the primary care dashboard. That primary care dashboard is now live. It's a dynamic dashboard and we're reviewing it all the time. We are checking and challenging some of the data on there, and certainly some of the timelines that the data is being reported on. So we've now formalised the governance structure for that. We have a subcommittee of the primary care operation group that is meeting regularly to identify any areas of concern. So the governance structure for reporting will be that would then get reported to primary care ops and quality group, which in turn would report to quality and safeguarding committee or the primary care committee, depending on where the issues lie. But you would see that information anyway, because my paper reports in both directions. Next on the list was just a quick update on the non-medical prescribing policy. That got launched at the beginning of April. We had really good response from the non-medical prescribers. They were given till the end of June to submit their annual ARTP form. We've had a really good uptake on it, and the meds management team are just chasing up the last few returns that we're waiting for. Non-medical prescribing data was shared with all the non-medical prescribers so that they could see their own data as well as compare themselves to their peers, and that has stimulated some really good conversations amongst the non-medical prescribers. So I'll have a further update for that at the next committee. And the last two things on the list were the COVID vaccination incidents. Obviously, we had a number of incidents that we worked closely with the PCNs on whilst they were going through phase 1 and phase 2, and we'll be using the learning for that to help support PCNs that opt in for phase 3. And finally, just a quick update on the hepatitis A outbreak that we had in the traveller community. There have been no further cases identified in Cheshire. However, these cases, this cluster of cases did happen while we were in the last lockdown. And so, of course, as soon as that lockdown was released, that particular population of patients then moved on. So it's difficult to track them, but Public Health England are keeping us abreast of any changes. But to date, there's been no more outbreaks in Cheshire. And any questions from anybody on anything that I've not covered?
Anybody got any questions? No. Nothing in the chat box and no one's waving to me. That's lovely. Well, thank you, Katie. We've been asked to note the contents of the report, and so they are duly noted. I'm sure everybody can agree that with me. Lovely. Now, Kevin, I need to know if you've got your lead plugged in for your computer now, so you don't run out of power, and we'll do the primary care ICT update.
Thanks, Pam, and apologies. Yes, handy IT tip for the day is ensure proper power cable is plugged in at all times. So this month's paper is for information. It's got some key points. I suppose the biggest thing in is a big section on projects. A lot of these have been delayed, obviously, due to COVID with primary care, both on restrictions of resource, access to buildings, obtaining equipment from around the world for laptops due to a shortage created by COVID. So there is a full schedule of work now underway, and that's utilising the funding we received from last financial year. And we're hoping we can complete a lot of them before the end of this financial year, with additional resources being brought in to support those within our ICT provider. So other key elements, I think some good news on there. Again, some funding that we had from previous year was the extension of the service desk ICT hours for general practice, the standard offering for as part of GMS contract support from 8 till 6 is the normal NHS digital funding for that, and we've extended this with work with Dr. Dan Jones, linking in with the PCN directors and PCNs of what hours would help them as an ICT service, having half an hour before they start work and half an hour to finish clinical record at the end of the day. Was the agreement, and that went live on the 1st of July, and that will now continue as part of the contract that the CCG provide to the practices for ICT. As always, we have a cycle of bid opportunities with NHS Digital for the standard business as usual replacements. So that's replacing IT equipment like PCs and desktops that reach a certain age, which is 5 years. We've bid this year, as per the paper, there's £750,000 for that element across the practices in Cheshire. Again, that's also used for things like firewalls and cyber security to help provide that support into the security across the network. Also this year we have had estates and technology funding. This funding has been worked up with James Birchall and the estates team and the PCNs and it sort of links in with Lorraine's updates on ARS roles. How do we use space utilization in the practices? What can we move IT-wise for old IT cabinets? things that aren't located well. How do we release some of that space through a capital bid investment for the practice? They can put more desks in to support the additional workforce. Again, as part of that capital bid, those additional bits of IT equipment will support all of those additional ARS roles. That's £250,000 this year for the ETTF fund. Both are waiting approval at the moment from NHS Digital and NHSX. Hopefully we'll hear about them in the next few weeks, which we'll bring back to the appropriate governance through Primary Care Ops and then to yourselves for the spend that's planned as agreement with practices. Also on the paper is a digital first funding, which this year is 409,000. This builds on some of the funding we had last year, and it's part of a 5-year NHS digital initiative to bring innovation to digital across England. This is part of an allocation that we received for Cheshire. We've had 1.5 million in total for Cheshire and Merseyside, with our allocation being the 409k. This is basically thinking outside of what we have as a standard offering, is what we use to bring in enhanced services into primary care. We're looking at, enhanced digital dictation at the moment. We're looking at training platforms for the new ARS roles, for some of the locum supports as well that come in. So there's a really clear way of, instead of spending time with a practice manager, go online and you can look at some of this information on some of the things that are practice specific that will improve, when you've got someone coming in for one day, it's a quick turnaround and that support for them. We've had some of this engagement meetings. Dan Jones has now merged the two PCN meetings for different places. We have one joint meeting with everybody on that he chairs. And Dr. Dan Jones is also involved in some of the discussions with the PCN directors on, and the HCP. Some of the work he does with them is how do we align some of this digital innovation at a bigger level and a local level to ensure that, the bids we put in bring some real benefit to primary care outside of the normal funding that we receive. That's pretty much the scope of the updates. If there's any questions, happy to support any of them.
Okay, has anybody got any questions for Kevin? No questions? Other committee therefore happy to know, or I've just no. Oh, Neil, you've come in. You said yes.
I'm a bit of a stuck record on this one because I Kevin probably knows what I'm going to ask already, because every time I speak to a GP, they are generally isolating at home and they're bemoaning their network speed, and I had it again this morning. So I don't know if you want to give a quick update on some of the work that you've been doing to improve connectivity through off-site working.
Sure, yes, thanks, Neil. So the initial, during COVID, we initially implemented a new virtual infrastructure for practices to use. This was, part of an initial demand. We invested £250,000 in that. That replaced a very aging system that coped with the additional demand in the first instance. The longer term strategy for that was to, with the investment in all the new laptops and some of the national guidance to support agile working and mobile working for clinical staff, and that extended to some of the practice staff as well, is there's new remote VPN software which effectively enables practice staff to have a work laptop, connect to the network while they're at home or anywhere where they've got a internet connection. So that could be in a pop-up clinic, it could be in a vaccination centre, so they will have access as part of that development. That's one of the key deliverables for this year, to expand that across all GP practices in Cheshire. I think some of the things we're still doing at the moment is that consistency model after the merger of the 4 CCGs and addressing some of those ICT inequalities. So like Neil said, that some practices have this, they're seeing the benefit of this, it's improved the speed and their access to EMIS and to the Docman systems, and hopefully within the next few months we'll complete that rollout across the whole of the GP practices.
Kevin, anybody got any questions or comments? No? Okay. So we're just asked to note that report, which I'm sure we can do. I'm not seeing any nods. Everybody's, I think, suffering from the heat at the moment. But yes, so we can approve. We can just nod. Yes, that's lovely. we know the report. Thank you, Kevin. Thanks for that.
Thank you, Pam.
We're now on to 3.1, which is any other business, and no one's notified me of any. Has anybody got any? No. Thank you. And so it just leaves me to say thank you to everybody who's sweltered through this part one of the meeting. There'll be another primary care commissioning meeting that's scheduled for the 11th of October, but it sounds like we're going to have one before then sometime. And for those of you who are coming back to part two of the meeting, that is on a webinar. It's not an MS Teams link, and maybe we need to have that taken away so people don't get confused. And if I'm correct, it starts at 4:15. So thank you for those people that have presented today. Thank you for your reports. And I'll see some of you later, and I'll see some of you next time. But thanks very much.